You know, usually when we talk about severe physical trauma, there's this unspoken expectation of like immediate intensive rehabilitation.
Oh, absolutely.
Right. Like if you tear a hamstring playing tennis or you, I don't know, snap a tendon on a morning run, the MRI shows the damage, the orthopedic surgeon assesses the tear, and you're just immediately handed this mandatory 6-month physical therapy plan.
Yeah, the path to recovery is completely mapped out for you. It's aggressively managed because it's treated as an urgent structural failure.
Mhm.
It demands intervention to restore basic human function. You aren't just left to figure it out on your own.
Exactly. But then you step into the world of childbirth.
Hmm.
And giving birth is arguably one of the most intense, extreme biomechanical feats a human body can endure.
It really is.
And sometimes nature needs a little help. Doctors have to step in to assist the delivery using specialized instruments, primarily a vacuum or forceps. Which brings up a massive, very common, yet rarely openly discussed anxiety for you, the listener. Do these instruments cause permanent damage? And more specifically, the core question we are looking at today, can a vacuum delivery affect your vaginal support differently from forceps?
And that specific question, it's actually a diagnostic blind spot in standard postnatal care. The assumptions people make about these two instruments and how they impact the pelvic floor long term, they rarely match the clinical reality we see in the data.
Which is why today we are laying a robust stack of medical literature on the table for this deep dive. We're pulling guidelines from the Royal College of Obstetricians and Gynecologists, the RCOG. We have this fascinating and honestly slightly terrifying 10-year retrospective study by Memon and colleagues.
Yeah, that one is eye-opening.
It really is.
Oh.
We're also looking at a prospective study by Kimmich on severe muscle avulsions, international data comparing maternal trauma rates in Canada versus Europe, and clinical insights on modern pelvic floor rehabilitation.
So the mission for this deep dive is to basically settle the debate between vacuum and forceps deliveries when it comes to pelvic floor trauma. We're going to unpack the actual physics of what happens to your muscles during an assisted birth and explore what this all means for your long-term recovery and your quality of life.
But to even begin to understand the data in these studies, I feel like we have to start by visualizing the anatomy and the tools themselves.
And best. We need to look at what these instruments are actually interacting with under immense pressure.
Okay, so I find it easiest to think of the pelvic floor like a thick, muscular hammock hanging at the very base of your pelvis.
That's a great analogy.
And this hammock has a massive, constant job. It literally holds up your bladder, your uterus, and your bowels against the constant force of gravity. Now, during birth, the baby has to pass through a specific opening in the middle of this hammock, which is medically called the levator hiatus.
Right.
It's basically like trying to push a bowling ball through the center of a tightly woven trampoline.
That is the perfect way to visualize it. I mean, the tension on those muscles is extreme. And when a mother is pushing, but the baby simply isn't descending, maybe the mother is physically exhausted after 30 hours of labor, or the fetal heart rate is dropping and the baby is in acute distress. The obstetrician has two primary tools to assist that passage through the hammock.
The vacuum and the forceps.
Exactly. The vacuum, which is sometimes called a ventus in the literature, and the forceps.
And reading through the descriptions in the sources, the mechanics of these two tools are wildly different.
Oh, completely.
The vacuum uses suction via a specialized plastic or metal cup. The doctor places it directly onto the top of the baby's scalp, waits for the mother to have a natural contraction, and as she pushes, the doctor pulls on the vacuum handle to guide the baby down.
But it relies entirely on cooperation.
Right. And I was reading that if the doctor pulls too hard or the angle is slightly off, the cup simply detaches. It loses suction with this loud popping sound.
Yeah, the detachment is actually a built-in mechanical limitation. It's a safety feature, essentially.
Okay, that makes sense.
The forceps, on the other hand, operate on a completely different physical principle. They're essentially two smooth, curved metal blades. The obstetrician carefully slides them inside the birth canal to fit securely around the sides of the baby's head, basically cradling the skull.
And then the handles lock together outside the body.
Right. Again, the doctor waits for a contraction, asks the mother to push, and applies traction to help deliver the infant.
See, whenever I visualize that, my intuition immediately flares up, and I imagine anyone listening is thinking the exact same thing. Logically, if you are sliding metal tongs, the forceps, alongside a baby's head, you are drastically increasing the overall diameter of what has to pass through that muscular hammock.
You're adding bulk, yeah.
Exactly. It takes up more physical space in an already impossibly tight corridor. So it seems incredibly obvious that forceps would cause way more physical stretching and trauma than a vacuum cup, which just sits purely on top of the head and doesn't add any width to the baby's skull. Is that intuition actually backed by the medical data?
Well, your intuition is spot on regarding the outcome, but the mechanism of the damage goes far beyond just taking up more space and causing more, stretching.
Oh, really?
Yeah. The clinical evidence overwhelmingly shows that forceps are significantly, measurably more traumatic to the pelvic floor, but it's the nature of the trauma that is most alarming here.
We're talking about something much worse than a muscle just being overstretched, like an old rubber band, right?
Much worse. We need to look at what actually happens to the levator ani muscle, that's the primary muscle group making up that hammock. A normal, unassisted vaginal delivery, or one assisted by a vacuum, causes major trauma to this muscle in about 10 to 34.7% of cases.
Okay, wait, up to 34%. That already sounds high.
It is, but when the literature says major trauma, it is specifically referring to an avulsion.
Meaning?
That means the muscle belly is literally torn completely off its anchoring point on the pubic bone.
Oh, wow. It is detached from the skeleton. That is a catastrophic structural failure.
It is. But when obstetricians use forceps, that avulsion rate jumps dramatically to between 30 and 65% of cases. You are looking at potentially doubling the risk of tearing the muscle completely off the bone.
That is just wow. And the Memon study really hammers this home because they didn't just look at women in the recovery room while everything was swollen and chaotic.
No, they didn't.
They tracked down women an average of 10 years postpartum and put them through 3D transperineal ultrasounds.
And a decade later, the structural differences were undeniable. They found that a levator avulsion was present in 49% of the women in the forceps group. Practically half of them were walking around with a detached pelvic floor muscle 10 years after giving birth.
Half of them. That's unbelievable.
Compare that to only 18% in the vacuum group. When researchers run the statistical analysis on this, the odds ratio for a levator avulsion comparing forceps to vacuum is a staggering 4.57.
Meaning you are roughly 4.5 times more likely to suffer this specific severe muscle detachment if your doctor uses forceps instead of a vacuum. Looking at the physics of it, I keep going back to the idea of mechanical leverage. The studies note that the pull forces exerted by a doctor using forceps can be twice as high as the pull forces used with a vacuum.
Right, because the forceps lock around the head, the doctor has immense physical leverage.
And the obstetrician can apply significant traction and even rotational force to turn the baby, which you simply cannot do with a vacuum.
You can't, because the vacuum has that built-in safety limit we talked about. If you pull too hard, the suction breaks and that cup pops off.
But the forceps never pop off.
Never.
So all of that immense pulling force gets transferred directly to the surrounding tissue, specifically the mother's muscular hammock, which perfectly explains why the muscle gets physically ripped off the bone. The sheer torque and traction are exponentially higher.
Yeah, the mechanical advantage of forceps is simultaneously their greatest clinical strength and their greatest danger to the maternal pelvic floor.
Which naturally leads to an obvious question.
I think I know what you're going to ask.
If the data from these 3D ultrasounds so overwhelmingly shows that forceps destroy the pelvic floor, tearing it right off the bone at a rate 4.5 times higher than vacuums, why are they even legal? Why wouldn't the medical community just universally ban forceps tomorrow and mandate vacuums for every assisted delivery?
It really represents one of the most difficult ethical and clinical dilemmas in medicine.
Yeah.
To grasp why forceps are still on the tray, we have to examine the Cochrane Systematic Review data, which synthesizes multiple massive randomized trials.
Okay.
You're completely correct that the vacuum is much safer for the mother's pelvic floor. The odds ratio for significant maternal trauma with a vacuum is just 0.4 compared to forceps. It is highly protective for the maternal anatomy. However, the vacuum is 1.7 times more likely to fail at delivering the baby.
Because of the suction breaking.
Right. If the baby is truly stuck or the mother's contractions aren't providing enough downward force, the vacuum simply doesn't have the mechanical power to finish the job.
And when a vacuum fails, the clinical scenario becomes an absolute nightmare, doesn't it?
Oh, it's incredibly tense. The doctor is standing there, the baby is still in the birth canal, often with a rapidly dropping heart rate indicating oxygen deprivation. What is the next step? The doctor has to reach for the forceps anyway.
The literature calls that sequential instrument use, right? You try to vacuum, it fails, so you stack the forceps on top of it.
Yes, and sequential use compounds the risks massively for everyone involved. The risk of major maternal hemorrhage, severe third or fourth degree tearing, and critical neonatal injury skyrockets.
So doctors try to avoid that entirely.
Exactly. Obstetricians are trained to anticipate this. If a doctor looks at a patient's anatomy, the position of the baby, and the fetal heart monitor and concludes this vacuum is going to pop off, they will often bypass it entirely. They go straight to forceps because forceps have a near 100% mechanical success rate of extracting the baby.
We also can't ignore the safety of the baby regarding the instruments themselves.
No, we definitely can't.
The vacuum isn't just a harmless plunger. The suction creates intense localized pressure on the infant's scalp. The studies highlight a significantly higher risk of neonatal cephalhematoma, basically bleeding under the scalp, and even retinal hemorrhage from the pressure changes.
And the baby's gestational age is a massive factor here as well. If a mother goes into labor prematurely, say at 34 weeks, forceps are almost universally preferred over a vacuum.
See, that feels counterintuitive until you think about the baby's development.
Right.
A premature infant's skull bones haven't calcified enough yet. They are too soft to safely withstand the intense suction of a vacuum cup without risking severe internal brain bleeding.
Precisely. The smooth metal blades of the forceps actually act as a protective cage around the premature skull, shielding it from the crushing pressure of the birth canal walls.
So the physician is forced into this terrifyingly delicate balancing act. They have to weigh the highly probable permanent destruction of the mother's pelvic floor against the very real potential of failing to deliver an asphyxiating baby or causing a brain bleed in a premature infant. It is a high-stakes decision made in a matter of minutes, often seconds.
It is, and because there is no perfect, risk-free answer to this dilemma, the sources show that medical cultures handle this completely differently depending on where you live.
I found this part so interesting. The lack of global consensus means your geography heavily dictates the level of trauma your body might endure.
The international data really highlights this stark divide. In Nordic countries like Denmark and Sweden, forceps use has plummeted to below 0.5%. They have essentially phased it out, relying almost entirely on vacuums and rapid emergency cesarean sections if the vacuum fails.
But then I look at the data coming out of Canada. Canada has the highest rate of maternal trauma after operative vaginal delivery among all high-income countries.
Yeah, the numbers are concerning.
The researchers outline a sort of perfect storm of systemic factors driving this trauma rate. First, they maintain a relatively high use of forceps, around 5.1% of deliveries.
Right.
Second, and this is where I really stumbled reading the source material, they have a remarkably low rate of protective episiotomies compared to countries like the UK.
That's a crucial point.
Now, wait a minute. Restricting episiotomies, which is surgically cutting the vaginal opening to make more room, has been pushed for the last 2 decades as a modern, progressive medical practice.
Yes, the idea is that natural tearing heals better than a surgical cut.
Exactly. So are these researchers actually suggesting that returning to preventative surgical cutting is better for the mother if forceps are in the room?
It comes down to the biomechanics of how tissue fails under stress. When a baby is delivered via forceps, the outward radial pressure on the vaginal opening is immense. If the tissue tears naturally under that specific pressure, the tear often propagates straight down, completely rupturing the anal sphincter. Yeah. The UK guidelines advocate for a very specific surgical cut called a medial-lateral episiotomy, a cut made at a 60-degree angle.
So it's like redirecting a crack in a windshield.
That's a great way to put it.
If you see a crack heading straight for the center of the glass, you drill a tiny hole at an angle to force the stress vector in a different direction.
That is precisely the physics of it. By cutting the tissue at a medial-lateral angle, the obstetrician redirects the shear force of the forceps away from the delicate anal sphincter and into the surrounding muscle and fat, which is much easier to repair.
But in Canada,
because Canadian guidelines generally advocate for restricting all episiotomies, doctors are hesitating to make that angled cut. And the research suggests this results in devastating unguided sphincter tears when forceps are applied.
and combine that with a decline in training opportunities for young doctors to actually practice using forceps safely, and you get Canada's alarming trauma rates. Okay, let's bring this back to the listener. Say you had a forceps delivery 5, maybe 10 years ago. You suffered this levator muscle avulsion. The muscle was torn off the bone. What does that actually mean for your daily life? Do you just feel a sense of, like, looseness forever?
We really need to draw a sharp medical distinction here between vaginal laxity and pelvic organ prolapse.
Okay.
Vaginal laxity is the subjective feeling of looseness, a noticeable reduction in sensation, often reported during intimacy. It's incredibly common, but heavily underreported because patients feel a lot of stigma bringing it up to their doctors.
Right. It's treated as a cosmetic or minor quality of life issue.
Mm.
But prolapse is a completely different beast.
Prolapse is a total structural failure. Pelvic organ prolapse occurs when the pelvic organs, the bladder, the uterus, or the bowel, literally drop down into the vaginal space because that muscular hammock underneath them has collapsed.
Because it's detached.
Yes. Going back to that 10-year Memon study, the 3D ultrasounds showed that a levator avulsion from forceps is heavily associated with severe long-term prolapse symptoms. The opening in the hammock was permanently stretched wide open.
The ultrasound showed that when these women actively tried to squeeze their pelvic floor, nothing happened.
Nothing.
The muscle was physically disconnected from the bone, so squeezing didn't close the gap. It's like trying to close a drawbridge when the lifting cables have been snapped.
That's exactly what it looks like on the imaging.
Which makes me incredibly skeptical of the clinical data on rehabilitation. If you are a listener who had a forceps birth and you have this avulsion, are you just a ticking time bomb for your organs to drop? The sources claim pelvic floor physical therapy works, but if the muscle is detached from the bone, doing standard Kegels sounds like trying to paddle a canoe with a broken oar.
It does sound like that.
How can physical therapy boast a 45% success rate here? What are they actually fixing if the strap is broken?
That is the crucial question. And you are entirely correct that standard unguided Kegels are practically useless for an avulsion.
Right.
If the muscle is torn, you will likely just squeeze the wrong surrounding muscles to compensate, which does absolutely nothing to support the organs. Conservative treatment only works when guided by a pelvic floor specialist using targeted interventions like biofeedback.
I was reading about the biofeedback process. It sounds fascinating. It's almost like trying to wiggle your ears. You don't quite know which invisible internal muscle to pull until someone holds up a mirror and you can visually connect the internal squeeze to the external result.
Yes, that visual connection changes everything. The physical therapist places sensors on the pelvic floor muscles connected to a monitor. The patient can actually see on a screen whether they are successfully firing the correct, intact levator muscle fibers.
Oh, I see.
Once they locate the right fibers, they use progressive resistance training.
So the goal isn't to magically reattach the torn muscle.
No, it's not.
The goal is muscle hypertrophy. You are aggressively training the surviving, intact parts in the hammock to grow thicker and stronger. It's like a backup generator taking over the entire grid when the main power line is cut.
That's a perfect way to describe it.
The surviving fibers take over the mechanical load of the torn ones.
And the clinical data shows that for vaginal laxity and early to moderate stage prolapse, this specific guided physiotherapy results in a massive reduction of symptoms.
What about for really severe cases?
For highly advanced prolapse cases where the organs are actually protruding, surgical interventions are required to physically rebuild the support structure. But the vital takeaway from the literature is this: a history of a vacuum or forceps birth is the missing puzzle piece. It explains why you are having symptoms, but it is a starting point for specialized treatment, not a permanent, unfixable destiny.
To bring all these complex threads together, the answer to our core question is definitive. No, vacuum deliveries do not cause more vaginal stretching or pelvic floor trauma than forceps. It is unequivocally the opposite.
Without a doubt.
Forceps are vastly more traumatic, generating immense mechanical leverage that is highly associated with severe pelvic floor avulsions, tearing the muscle directly off the bone and leading to long-term pelvic organ prolapse.
However, because the vacuum carries a higher rate of mechanical failure and introduces distinct fetal risks like scalp bleeding and danger to premature skulls, obstetricians are forced to make a harrowing case-by-case calculation. They're essentially trading maternal anatomical safety for the immediate, life-saving extraction of the baby.
It is a brutal calculation. And as we wrap up this deep dive, I want to leave you, the listener, with a final thought to mull over something that really highlights the absurdity of how we view postpartum care.
Yeah, this part is so important.
The clinical literature notes that during a vaginal delivery, the levator antemuscle, that hammock, undergoes a degree of distension and stress that would medically rupture any other skeletal muscle in the human body. Think about the gravity of that.
It's immense.
If a professional football player or an Olympic sprinter suffered a massive skeletal muscle avulsion. If they tore their hamstring clean off the bone on live television, they would be in an operating room the next morning.
And that surgery would be followed immediately by 6 to 9 months of intensive, mandatory, globally recognized physical therapy.
The medical community would consider it gross negligence to do anything less.
Oh, absolutely. They'd lose their medical license.
Yet millions of women undergo assisted births with forceps or vacuums every single year, suffered the exact same severity of skeletal muscle detachment, and are simply handed a baby, sent home, and told to come back for a generic checkup in 6 weeks.
It's hard to justify.
Why hasn't postpartum pelvic floor physical therapy become a universal mandatory standard of care after an assisted delivery? If your internal hammock was subjected to forces that would snap a professional athlete's leg muscle, you deserve the exact same level of diagnostic imaging and intensive rehabilitation.
You really do.
Take the data from this deep dive. Advocate fiercely for your own recovery, and seek out a specialized pelvic floor assessment. Don't let anyone convince you that living with structural failure is just a normal part of motherhood.